state-of-the-art echocardiography. So his talk today will be slightly different. It has to do with electrophysiology, but it is more focused on malignant mitral valve prolapse. Franco, we are anxious to hear what is this phenomenon, malignant mitral valve prolapse.
Thank you, Petros. Thank you, George, to inviting me once again, despite my previous talk. So this means something. Well, a role of imaging in electrophysiology and malignant mitral valve prolapse. Just have a look at the prevalence of mitral valve prolapse. So when we talk about mitral valve prolapse, we talk of this kind of a prolapse. So bileaflet prolapse with the kind of redundant tissue. Well, if you look at this, if you focus at this prolapse, the prevalence is pretty low. We have the total prevalence in all subjects 2.4%, and with a slight increase on women and less in men, but the prevalence is almost this 2.4, 2.5%. But the first question is this mitral valve prolapse really a malignant entity? Well, data are conflicting. Indeed, if you look at the general population, well, in the general population, the mitral valve prolapse is actually a benign entity, more benign than we thought before in the general population. And this is a paper quite published quite recently in 2016, in which they just say that if you look at the bileaflet or single leaflet prolapse, but bileaflet prolapse, there is a tendencies of more ventricular tachycardia, but there is no tendency of a more implanted cardiac defibrillator. There is no tendencies of ventricular fibrillation or cardiac arrest. For all-cause mortality, seems that having mitral valve prolapse is better than not having, because the mortality is less in these patients. Of course, this is a trick of statistic, but this is the conclusion of the study. So they said that there is no associated with increased risk of cardiac arrest and ventricular fibrillation, but even better survival compared with the non-patient with the with the single leaflet prolapse or mixed controls. This is a statistical trick, but in any case, this paper showed that there is no worry about this entity. However, so this is the first question. In general population, mitral valve prolapse has a benign profile. There is no doubt about that. However, if you look at other papers, so this is a paper by Devereux, who showed, this is a very, very old paper, who showed the mitral valve prolapse with angiography or with MMO, the echocardiography. And this paper, they say that there are 4 complications with mitral valve: sudden death, infective endocarditis, spontaneous ruptures, and the progressive mitral regurgitation. So this is the one paper that can make us very doubts about the profile of mitral valve prolapse. This is another paper which was published in 1988, in which showed that more than 1/3 of the patients with the mitral valve prolapse in a referral hospital, they have a lot of complications. Ventricular tachycardia, ventricular fibrillation, sudden death. So this is another paper which showed that the mitral valve prolapse may be dangerous. And this is a paper from Grigioni in Mayo Clinic, who showed that the sudden death in mitral regurgitation due to the flail leaflets is there is 90% of incidence of sudden death in these patients, which means 1.8% per year. So, once again, the first question is the mitral valve prolapse a malignant entity? We can say probably yes in hospital-based or referral series. So in series which are looking exactly to the mitral valve prolapse, there is a recognizable percent of patients with mitral valve prolapse might have serious complication, including sudden cardiac death. So at this point, the second question is, there are echocardiographic characteristics that might identify the subgroup of the patients at the risk of a complex arrhythmias and sudden cardiac death. Well, just go back to the paper of 1985 on Nishimura, who showed that if the patients with mitral valve prolapse are redundant leaflets, then there will be a small percentage of the cases, it's 10% of the cases in which it could be sudden death, infective endocarditis, cerebral embolic event. If the leaflets are not redundant, then there is no complication at all. And this redundant leaflet was made by M-mode echocardiography at the time with these several lines of leaflets, which is a little bit problematic and debatable. But in any case, this was the paper. But this was another paper from last name Arthur Weyman, who showed that this kind of leaflets, redundant B-leaflet prolapse, might have are at higher risk of dynamic complication, infectious endocarditis, and so on. So this is another paper showing that this kind of redundant leaflet, B-leaflet prolapse, might identify the patients at risk. This is another paper by Mayo Clinic who showed that, once again, a potential malignant mitral valve prolapse is characterized of, and you can see here the images of redundant B-leaflet leaflets. So, if we say that the question 2 was there is echocardiographic characteristic might identify the subgroup of patients at risk of a complex arrhythmia, yes, probably B-leaflet prolapse with the leaflet thickening and redundancy might identify patients at risk. But the question 3 is one of the most important because what is the link between the redundant B-leaflet mitral valve prolapse and the complex arrhythmias and the sudden death? Once again, we have to go back to the literature. In 1992, Anthony St. Philippe, a fellow of Bob Levine, showed that the papillary muscle traction in mitral valve prolapse. So what they show is that during the systole, in mitral valve prolapse with B-leaflet mitral valve prolapse, during the systole, the papillary muscle does not shortening as usual in normal individual, but elongated because it's a tract, have an attraction from the chordae tendineae and the leaflets, which are redundant and prolapsing. So this paper was almost disregarded, even though they just give the idea, because they said this finding would be important regarding the genesis of arrhythmias. But this paper was disregarded for many years until there is another paper. Quite important because this is paper for Han, who showed that bi-leaflet mitral valve with the MRI, bi-leaflet mitral valve prolapse, they have some tip of the papillary muscle, some scar. And this is linked with the traction, who St. Filippo showed several years before. Indeed, what they said at the conclusion, this pretty important paper, hyperenhancement of papillary muscle on late gadolinium enhancement is often present in subgroup of patients with complex ventricular arrhythmias. It was much more recently, 2 years ago, Cristina Basso from Padua University, who showed that this scar is not only on the tip of a papillary muscle, but also on the basal wall of the left ventricle. So the question 3, what is the link between mitral valve prolapse and arrhythmias? Well, it's probably systolic stretch of myocardium close to the valve, tip of papillary muscle, basal left ventricular region, might develop regional fibrosis and electrical instability. But there is another point which I want to share with you, is the so-called MAD, mitral annulus disjunction. Indeed, this was the first paper who we listen about this new pathological entity. It was published in 1986 by Hutchins, and this paper, they show that in normal individual, there is a classical junction between atrial wall, ventricular wall, hinge line of a tricuspid valve, and the so-called annulus here. But in patients with bileaflet mitral valve prolapse, then this is not anymore the classical architecture. Indeed, the mitral valve leaflet is inserted on the left atrial wall, and the crest of the ventricular wall is detaches this junction between this complex here by a piece of connective fibrous tissue here. So this was called mitral annulus disjunction. But this anatomical architecture in mitral valve prolapse was once again discarded because this is we suggest that floppy mitral valve develops from hypermobility and is usually secondary to disjunction mitral valve annulus fibrosus. So they just say that this was the first cause of a mitral valve prolapse. But once again, I told you that this was disregarded because 1 year after this first paper, Angelini, the group of the Robert Anderson in London, showed that this disjunction could be present also in a normal individual. So they talk that this is exactly a anatomical variation without any consequences. However, very recently, once again, the School of Padua, the University of Padua, Perazzolo Marra showed that this disjunction is present in patients with mitral valve prolapse or in cadavers with mitral valve prolapse, and also in patients with mitral valve prolapse and the complex arrhythmias, as you can see here. And there is still necrosis, fibrosis of a papillary tip of the tip of a papillary muscle and on the base of the left ventricle. Indeed, this mitral annulus disjunction is a constant feature of arrhythmia mitral valve prolapse with the left ventricular fibrosis. So MAD is important, mitral annulus disjunction is important. But look at these 3 papers I showed you before. They do know nothing about MAD. This was paper published before the MAD was characterized, before this kind of architecture was characterized. But nonetheless, when you look at the images that they published in this paper, there is a disjunction. They don't know nothing about that. They just showed the bileaflet prolapse, but look at this, there is a disjunction. And also here, there is a disjunction, and also here, there is a disjunction. So this is a proof that disjunction means something in mitral arrhythmias of mitral valve prolapse. So the question 3 is, my mitral annulus disjunction might be the link between redundant leaflet of mitral valve prolapse and complex arrhythmias and sudden death. But if you look at the pathanatomy of mitral valve prolapse, you can have 4 types of mitral valve prolapse. Fibroelastic deficiency plus, form Froste, and Barlow disease. These are characterized by an increase of the leaflet tissue, so an increase of redundancy of leaflets. And this can be very well characterized by 3D echo. If you look at the FED, you can see here, or FED plus, you can see here, or form Frost, you can see here, or Barlow disease, you can see here. So the question is, where is the disjunction here? Well, in our not yet published study, we have more of 80 patients, and the Barlow disease are the only situation in which we found the disjunction. So Barlow disease is associated with disjunction. No form of Frost, non-fibroelastic deficiency, of course, no control, at least in this study in our institution. And this is an example. You see, this is a classical Barlow disease seen from a lateral perspective, so you can crop these images in a zeta plane, like in this direction from in front to behind, and then you can see this. It's a classical disjunction here, you can see. Or in biplanar, in this section, which is where you can see all the posterior wall, or the posterior leaflet here, you can see that the disjunction is here. And this is a paper of Lee, who showed that disjunction in this Barlow disease is prevalent in the lateral and posterior part of the annulus, and spare a little bit of medial of the annulus, as you can see here in these images. And what they say is that in end of the systole, because of this configuration, in end of the systole, the mitral annulus enlarged instead of contracting. But this is not unexpected, because the leaflet is attached on the atrial wall, which is, of course, the end of the systole larger than in end of the diastole. So this is exactly what we expect, because here there is not any more annulus at all. The leaflet is attached on the wall of the left atrium, as you can see here in 2D echo and in MRI. But this is the most interesting paper, very recently, 2018, last years, in which there is still another paradigm. This paper show they focus on the MAD. So they just have 116 patients with mitral annulus disjunction. Well, of this, 90% was associated with the mitral valve prolapse. And they look that the 7% of this 90% of patients had ventricular tachycardia and cardiac arrest, acute cardiac arrest. Aborted, sorry, cardiac arrest. But look at this part here. The MAD was present without mitral valve prolapse. And this is what Angelini, several decades ago, said, that the MAD is a variant of a normal in normal patients. But these are really normal patients? Look at here. Of this, 31% had aborted cardiac arrest or ventricular tachycardia in comparison with the prolapse. So what the new paradigm is that the mud itself, not a prolapse, but the mud itself appears to be an arrhythmologic entity, independent of a concomitant mitral valve prolapse. This is a new paradigm that we have to look at and we have to understand better. So the question 4 is, but if you have MAD, mitral valve prolapse, and severe mitral regurgitation, so you need to repair this valve, the surgical repair may reduce the risk of arrhythmias and sudden cardiac death? Well, actually, we have very few data. This is one data in which say that mitral valve repair results in suppression of ventricular arrhythmias. So surgical repair may have an important role. But this is the most important paper I found in the literature with just very few patients. And they say that if this is the post-surgical follow-up, you can see that ventricular tachycardia are much less than before in the pre-surgical follow-up. Ventricular fibrillation are much less than before. Shock are less than before, and the total of these 3 complications are much less than before. So they concluded that this early observation, leaflet matter associated with a reduction in malignant arrhythmias, appropriate shock therapy. So the question 4 is, could the surgical correction appears, because there are very few cases, to be associated with a reduction of malignant arrhythmias and appropriate shock therapy. So just to summarize, in general population, mitral valve prolapse has a benign profile, no doubt about that. So if you have a mitral valve prolapse, don't care about that. In hospital-based and referral series, so when you look just at the mitral valve prolapse, a recognizable percent of patients may have a serious complication, including sudden cardiac death. Leaflet prolapse with the leaflet thickening and redundance may identify patients at risk due to the fact that systolic stretch of myocardium close to the valve, so means the tip of papillary muscle and basal ventricular region, might develop regional left ventricular fibrosis and, of course, electrical instability. MAD, mitral annulus disjuncture, is likely to be the link between morphology and arrhythmias. But this is the most important thing, MAD itself, with or without mitral valve prolapse, could be an arrhythmologic entity. And finally, in patients with Barlow disease, severe mitral regurgitation, surgical correction appeared to be associated with a reduction in malignant arrhythmias and appropriate shock therapy in mitral valve prolapse. So just let me finish with your impression, which is also my impression. So that's why I wrote. Since before I came here, I was confused about this subject. Having listened to your lecture, Dr. Faletra, I'm still confused, but a higher level. Thank you very much for your attention.
Thank you so much for your very detailed and elegant contribution to this very intriguing clinical topic. We have to confess that we face occasionally this scenario, and I will take the opportunity, having two experienced electrophysiologists in the audience, Professor Fragakis and Professor Dilaveris, what's your experience about this topic? Is there any experience of yours relating the evidence of arrhythmias, malignant arrhythmias, and this entity?
Thank you very much. Thank you very much for the excellent lecture. To be honest, I'm more confused after this lecture.
I know, me too.
Probably because you raised an issue that, from our point of view, we don't look very much when we search the cause of sudden death in patients without an obvious substrate. I would say that is an under-recognized issue, and actually I followed with huge interest your lecture, and I was thinking several things. One question that I would like to address is, do you think that we should introduce a beta blocker in every patient with severe prolapse? Because my understanding is that one of the reasons of this sudden death is overstretching after systole of LV. So if we give an agent which reduce this brisk, say, contraction, we may expect to reduce the possibility. Actually, this is an old-fashioned therapy with beta blocker in prolapse. What's your opinion?
Well, if you have a patient with bileaflet prolapse, a redundant tissue, leaflet tissue, and mitral annular disjunction, well, probably you have to focus on these patients and make a Holter or other thing that they can have some complex arrhythmia, unrecognized complex arrhythmia. In that case, yes. We do have a couple of cases in which we implanted the ICD because of very complex arrhythmias, starting from the morphology. They do have a palpitation, something like that, and we did the echo, and with the echo we recognize a prolapse and MAD, and then we do everything, including CEF, and then we discovered that these two patients have a lot of arrhythmias and complex ventricular tachycardia, and then we implanted ICD. But of course, yes, the first step would be beta blockers, I think.
There are data from the past, before Professor De La Veris state your statement. There's a lot of, some data from the past stating that autonomous dysfunction is there with Barlow disease. And also there is recent data, autopsy data from St. George's database, anatomical database, stating that in non-severe Barlow disease with sudden death and the lone finding being the Barlow disease of the valve, they have valve fibrosis of the LV, so they've introduced the hypothesis of Barlow cardiomyopathy.
Yeah, it could be MAD cardiomyopathy or MAD, so mitral, because so far we don't look at this kind of anatomical architecture. But probably it's this anatomical architecture which is the trigger for complex arrhythmia. So now we know, and I just tell my fellows, please, any patients who had the palpitation coming to have an echo or MRI for palpitation, something like that, please look at this particular, and sometimes they found it. Because if you don't know, you don't look, you don't recognize. Indeed, the paper that I showed you in which they say that the bileaflet prolapse and redundant tissue is a risk, in all of this paper, there is MAD. Even though they don't describe MAD because they don't know at that time. So MAD probably is the point, something that we have to study. This is just a beginning.
For clarification, I don't understand MAD. I don't like the word MAD. But do you mean, is it the same as mitral commissural prolapse? Because what you showed, I would diagnose commissural P2 with commissural prolapse. It's a commissure that is prolapsing.
Yeah.
Is it, what's the difference between
No.
commissural prolapse?
In prolapse without MAD, the hinge line of the leaflet is in exactly where they have to be, atrial wall, ventricular wall, hinge line. In mitral annular disjunction, the hinge line is here. So there is a part of this structure which is, there is nothing except a kind of fibrous band. And this is what they found, and this is what we are studying now.
So the final comment from Dr. Dilaveris.
Dear Professor Faletra, I personally have no experience on Barlow disease and the associated malignant arrhythmias. But after your lecture, I feel more safe because recently I discharged on beta blockers a 70 years old lady that's had a single posterior leaflet prolapse only, and she had a negative MRI concerning the presence of scar, of fibrosis. Yeah. Actually, because she presented with ample extrasystoles, ventricular extrasystoles, and very short runs of no-sustained ventricular tachycardia, I had to perform a electrophysiology study that was absolutely negative. So she remained on beta blocker therapy, nothing else.
Yeah, I agree with you. Probably this pathology is going more and more diseased with the time. So probably if you look at these 10 patients in 3 or 4 times with MRI once again, probably you can discover small scar on the tip of papillary muscle.
Okay, so we shall reconvene with Professor Faletra in 15 minutes. You are engaged to give another excellent lecture. So looking forward for the next 15 minutes.
Thank you.